All right. Good morning, everybody. Thanks so much for joining us for the digital pilot program pitch competition. I'm going to hand things off to our fearless leader, Sarah Biber, and she's going to give a quick introduction.
Okay, thanks, Brittany. Hello, everyone. Thank you and for joining us, and welcome to the inaugural NACC and Gates Venture digital pilot program pitch competition. Next slide. My name is Sarah Biber, and I'm the Executive Director of the National Alzheimer's Coordinating Center, which is funded by the National Institute of Aging and serves as the centralized data repository and communication and collaboration hub for NIA's Alzheimer's Disease Research Centers program. So Alzheimer's disease and related dementia research is entering the digital age. There's a huge opportunity to leverage digital tools to advance Alzheimer's disease and related dementia research and discovery, and to make this research more inclusive. A key focus of this award program, which is a partnership between Gates Ventures and NACC, is to accelerate the pace of digital innovation in Alzheimer's disease and related dementia, and to facilitate impactful collaborations between academia and industry. We're interested in funding pilot projects that leverage technology to enable richer and more objective data collection with less burden for participants in ADRCs, and that advance the development and validation of digital biomarkers down the line. The awards provided through this program will create pathways for impactful digital technologies to be applied within NIA's Alzheimer's Disease Research Centers program and beyond. Next slide. So this program was brought to you by a partnership between Gates Ventures and NACC, and I want to thank my colleague Niranjan Bose and his team at Gates Ventures for making this program possible. I also want to thank Nina Silverberg at the National Institute of Aging for her partnership in shaping this program. Next slide. So we're fortunate to have some incredible judges with enormous expertise participating in the program today and along the way. So we have Dr. Niranjan Bose, who is Managing Director, Health and Life Sciences at Gates Ventures. We have Linda Lee, who is a partner at Health Information Technologies at Cleveland Clinic Innovations. We have Dr. Vinny Baranek, who's the principal at Engine Ventures. We have Hugh Chang, who is the former Director of Maternal, Newborn, and Child Health at Gates Ventures. We have Xuan Gui, who's, love his title, Chief Disruptor at Health Disruptors Incorporated. We have Dr. Barbara Tate, who's a venture partner at SV Health Investors. We have Omkar Kulkarni, who is at Children's Hospital in Los Angeles and is also the Director of KidsX. We have Rachel Shaw, who's the operating partner at Engine Ventures. And we have Dr. Jason Hassenstab, who's director of the CTR lab at Washington University. I also want to thank Jessica Roberto, who is Associate Director of Innovations at the University of Washington Burke Center for Entrepreneurship. And I also want to thank Brittany Hale on my team at NACC. So her excellent management of this program has been instrumental in ensuring its success. So thank you, Brittany. Next slide, please. This program was open to anyone. So we received numerous strong proposals from across the country. Today, you are going to hear from our top 6 finalist teams. They have each proposed digital solutions that we really believe has the potential to transform Alzheimer's disease and related dementia discovery and translation. We're very excited about all of them and wish them all good luck in their pitches. Next slide. The data that is collected through the selected projects will be integrated with other standardized Alzheimer's disease and related dementia data modalities at NACC and be made freely available to researchers everywhere. So we're committed to working with awardees to scale successful projects across the full ADRC program and beyond. And together, we really believe that this data will open the door to better early detection, diagnosis, prognosis, tracking, treatment, and hopefully prevention in Alzheimer's disease and related dementia. So with that, I want to get to the exciting part, which is hearing these wonderful pitches. So I will, let's go to the next slide and just give a little overview of, Brittany, did you want me to give an overview of this, or was somebody else going to jump in and walk through the agenda?
Oh, you can give a quick overview.
Okay, great. So we're next going to proceed to the first 3 pitches. There'll be actually, I think first a brief introduction to the pitching process. We'll then have a break. We'll do another 3 pitches, another break. And then I hope that many of you will be able to join for the Ask Me Anything virtual poster session, where you'll have a chance to speak with some of the members of these teams. So with that, I will pass back off to Brittany. Thank you again for being here with us today for the inaugural kickoff of this inaugural program. We're very, very excited about it.
Awesome. Thank you so much, Sarah. Next slide, please. All right, now I'm going to hand things off to our moderator, Jessica Roberto.
Hi, everyone. Thank you again from joining. I'm just going to go quickly over what the pitching process will look like, and then we'll jump right into it. So next slide, please. So for those who aren't familiar, and hopefully our pitches are familiar with this, the teams will each have 6 minutes to pitch. And then after the 6 minutes, we'll have a short 4-minute Q&A with the judges. At this time, we're only going to have judges asking questions. For those of you with questions, please follow up with each team individually later on in the poster session rooms that Brittany mentioned. And those will take place directly after all of the pitches have concluded. I will be calling on the judges one by one as they raise their hands. Next slide, please. Pitches will be scored by our judges using the following criteria, the most important one being impact. Second one is viability of the proposal. 3 is the presentation quality of the pitch. 4th is the team that they've built around the project. And 5 is addressing accessibility and equity. And after all of the pitches are concluded, the judges will move to a separate room to deliberate and will submit their recommendations to the NACC team and to Gates Ventures, and the winners will be announced in early to mid-June. Next slide, please. So important reminders for the room as a whole. Please do not interrupt the presenters during their pitches or the judges during their questions. We ask that you remain on mute during this time. During the Q&A, again, only judges will be asking questions. This is imperative for keeping us on time and for the scoring process to make sure the judges get all of their questions answered for deliberations. And as I mentioned, you'll have a chance to ask your own questions as an audience member to the teams directly during the virtual poster session after the pitches are concluded. Next slide. And with that, I think we are ready to get started. So it's my pleasure to introduce our first inaugural pitch of the session. Is the Effect AD team presenting on everyday frequent functional evaluation with cross-cutting technology for Alzheimer's disease. So Dr. K, whenever you're ready. Please start.
All right. Well, thank you. Good morning. Good afternoon. Please, first, next slide. And the next slide. Let's dive in with the most important thing, which is impact. Our goal is ultimately to transform the effectiveness of our ADRD research and ultimately clinical care and support by changing the way we assess function. And that's our context of use, really assessing and monitoring function in the real world. We will do this by using home-based activity sensing and experience sampling. And this procedure, which we'll talk about in a moment, provides continuous objective measures of everyday real-world function. This is different than the way we assess function currently, which is annual, brief, proxy-based, or self-report assessments. We can really do better. If we do this, we can accelerate the development of new therapies because the high-dimensional data allows us to reduce sample sizes or time needed to complete trials. This will save us time and money, and also, importantly, increase the accessibility and equity of our research as the functional assessments are person-specific and can be deployed widely outside of traditional clinic-based settings. Next. How will we do this? Well, the technology that we have is simple but sophisticated. We combine bracelet-worn sensors with Bluetooth beacons that are strategically placed about a home. These provide activity by location over time continuously. It allows us to then assess motor function, for example, by total activity in a day or room transitions, sleep measures, such as sleep efficiency or time in bed. Importantly, social function and interaction with time together or apart by a patient with dementia or person with dementia and a caregiver in or out of the home. Cognitive function is uniquely assessed by how individuals use a device, their smartphone or laptop, to answer weekly brief questions. These questions provide important context regarding life and health events, such as medication changes, visitors, as well as internal states, such as mood, loneliness, or pain levels. All of this can be combined to provide these continuous, objective, meaningful real-world measures of function. Next, please. I've been very fortunate to be able to assemble and work with an incredible collaborative team with decades of experience in deploying technology in clinical studies of ADRD. My colleagues at OHSU, UCSF, the South Texas Alzheimer's Disease Research Center, as well as Panoramic Digital Health, our industry partner, have all the requisite expertise needed to conduct this research. Things such as patient engagement, deployment of technology to multiple sites, IRB approvals, data management, data sharing, and the business practices needed ultimately to be scalable are all contained within this team. We also include our patient groups as part of the team. Next. This approach and this research is entirely feasible. Why? Well, we have tremendous experience using the overall remote functional assessment paradigm in multiple, over 25 ADRD relevant studies, including in 5 ADRCs. We've deployed this approach to thousands of participants, including underrepresented minorities. This experience has provided us with ready templates to rapidly start up our study. We have all the IRB approval pathways, training procedures, and protocols to sustain this research. Importantly, Panoramic has also successfully deployed their technology globally in studies in the US, Europe, Africa, Australia. Specifically in this study, we want to affirm the feasibility of adopting this objective functional assessment paradigm using the Panoramic system across ADRCs. And this is going to be with a stringent test of by deploying in diverse populations in 3 different locations, low-income older adults with or at risk for MCI in the Portland metro area, people with behavioral variant frontotemporal dementia in the Bay Area, and Mexican-American older adults with dementia with Lewy body disease in South Texas. Next. Is this scalable? Well, first of all, it's inherently going to be scalable in the sense that there's a wide and urgent global market for developing meaningful therapies. Our target market is really the clinical research enterprise, both academia, the ADRCs, as well as industry, who are ultimately developing these new therapies. I've already mentioned why scaling this up is entirely feasible because of our deep experience, both in the ADRC and academic world, as well as Panoramic Digital Health, which is a company that has a long experience in FDA qualified or regulatory qualified development. Finally, scalability depends on sustainability, and this can only be achieved by having data that's available to everybody. So access to the raw data will be fundamental. This translates into a really device diagnostic approach. So really anybody will be able to use this approach, and we think it will be important advancement for our future in research. With that, last slide, please. I want to thank everybody and look forward to your questions.
Great, thank you for the presentation, Jeffrey. I'll start with Barbara, who was quick off the draw.
Thank you. So you allude to or state that you would reduce sample size by using the data that you're collecting with your system. Can you give us a little idea as to whether that's specific to the stage of disease, or do you really expect that to be, that we could reduce sample size in early Alzheimer's disease, for instance?
Yeah, so we've done simulations with this kind of data. Actually, it's been done in multiple data sets, digital data sets, that show that the individual data, frequent data, allows one to get a precise estimate of change much more rapidly than in the sparse kind of data collection where you just get a baseline and a 6 months or a year later data. And so that's where this idea comes from. And the ability to make those pronouncements, if you will, really comes from having the data to do those calculations. It's like any sample size calculation. So you need the digital data to do that calculation, but it's clear, and in fact, we've shown this independently by different statisticians, that you can reduce sample sizes and/or time because of the nature of the kind of data that one is getting. And I should also just quickly mention that at the severe stage, even where you might have a symptomatic treatment where you're trying to hopefully, for example, improve agitation, one can begin to look at N of 1 kinds of approaches because you can do very frequent assessments looking at A, B, BA kinds of designs because you have the outcome measures there very frequently obtained.
Great, thank you. Shwen.
Yeah, hi. Thank you for the presentation, Jeffrey. Couple of quick questions. I think one is, can you talk a bit about how your technology works? Is it proprietary? Is it using a consumer device? And then also, have you already developed the algorithms and now you're just testing it in specific populations? Or are you collecting the data in order to develop the biomarkers and the algorithms in general?
But Jeff, shall I give an answer about the technology? So
Absolutely.
yeah, so just I'm wearing the bracelet here. So the bracelet was developed actually by Panoramic Digital Health, working very closely with ST Microelectronics, which is one of the world's largest manufacturers of MEMS sensors. And the aim was to have a very open architecture in terms of configurability, in terms of cybersecurity, hardware encryption, everything on the device, and to provide a technology that could not just make measurements from the sensors, but control for variability by having these Bluetooth beacons, which are placed around the home. You just ask people to put them where they spend most of their time, in the room, bedroom, living room, etc. And then we can work out the location. We also have information about, for example, the room temperature. So that really helps us control for the variability. All that raw data is then transferred. We've got 2 data streams. We've got a compliance stream, which is real time, sent out multiple times a day, which confirms the device is being worn and gets you some high level data. And we can also extract the full raw data if we want to. And we've got analysis pipeline that can detect those location and derive features that we then use in the subsequent analysis. So that we've already got that in place. But in terms of developing more sophisticated functional measures, sort of co-creating them with the patients in these studies, absolutely, we intend to continue to innovate. So we've got the core analysis, but we intend to innovate and optimize, co-creating better measures with the patients and participants in the studies.
Great, and I think we have time for one more question probably. So Rachel.
Hi, thanks for the clarification on how the technology works. Actually, my question would sort of follows on with just a little bit more explanation around the deployment. So you mentioned the beacons are placed in the rooms. Can you speak a little bit more about sort of the setup that's required and how this is installed and how that plays into how you think about scale and deployment?
I'll give an initial answer, then hand back to Jeff. So the way we've done this in several other studies of similar size is we have actually shipped devices and done a video call or a voice call to set it up. So we explain what you do. You just take the devices out of the envelope, and when you're talking to people, so this is where we're having here patients who will have a carer, a supporter with them who can help set this up if they've got serious cognitive impairment. And they can position those things in a stable way. They automatically monitor themselves, so we know if they get moved or knocked over or anything. So that stability is detected. So we found it actually. We had really good feedback in the usability studies on this data in terms of being deployed in that way. It can also, of course, be given to people when they're at a clinic visit, and they can take it home and deploy it. But we started doing studies in COVID, and we had no choice but to ship it, and it worked remarkably well.
Yeah, I just want to add to that by saying that we we've been doing this kind of research for literally decades, and you really have to look at things in the populations that you're proposing to work with. And the ADR, and in fact, even including the ADRC environment. So we need to be able to do this feasibility study in these diverse populations within ADRCs to understand ultimately how this will be most effectively deployed and scaled within the research context, and then ultimately, hopefully, scaling out to even care. But that's down the road. Really, right now, the key is we need to have better ways, more effective ways of understanding this basic concept of functional ability. And we really think that this approach adds really unique data that we previously didn't have access to develop any new therapies on meaningfully.
Great. I think that's a wonderful way to end it on a strong note. So thank you, Dr. K and team. We're going to transition to the second pitch at the moment. So next slide. And while we do that, judges, please submit your scores for the first pitch. Give you a few moments to do that. I'm proud to present characterizing sleep-wake activity patterns across the spectrum of AD and ADRD by Dr. Joseph Weiner. Please come on down.
Hi, thanks so much. So my name is Joe Weiner. I'm a postdoc at Stanford University studying sleep and aging and Alzheimer's disease. And I have deep roots in our ADRC at Stanford. I'm a rec scholar and I contribute to both the clinical and imaging cores. Next slide, please. So we all know the ADRC network offers an incredible national infrastructure for studying Alzheimer's disease, prioritizing harmonization and accessibility for clinical, neuroimaging, and biofluid data. Our proposal is to develop a platform in the same spirit as these other modalities to collect sleep and physical activity data across the NACC ADRC network using continuously worn wristwatch accelerometers. I'll refer to this data as actigraphy. This national harmonized actigraphy dataset would provide both raw actigraphy data and key calculated variables of interest to address mechanisms by which changes in sleep and activity influence aging and Alzheimer's. Our pilot proposal begins with Stanford and Vanderbilt, two centers with existing strong collaborations, yet serving different regions and populations. Next slide, please. We have an amazing team of early career researchers bridging epidemiology and neurobiology of sleep and physical activity. Our core team of sleep and actigraphy investigators are complemented by our advisors who represent some of the best minds in harmonizing large aging and Alzheimer's data sets within the ADRC network and beyond. Next slide, please. So why collect 24-hour activity data? You probably already know that sleep and physical activity are important lifestyle factors in the progression of Alzheimer's disease and other dementias. Epidemiological and mouse model data suggests worse sleep and less physical activity in late life are associated with risk of cognitive decline. And because pathology aggregates in sleep and wake regulating brain regions early in the disease course, activity changes also represent an early symptom, which can have consequences for cognition and daily function. Because sleep and activity represent both risk factors and symptoms, combining real-world measurement of 24-hour activity with longitudinal in vivo biomarkers already harmonized in NACC would provide data critical for discovering new digital biomarkers for early detection and differentiating disease processes. Next slide, please. Beyond the importance of the science, the reason this project would be perfect for NACC is because this data is low burden, feasible within ADRCs, and scalable. The device we're proposing for data collection is the Axivity AX3 triaxial accelerometer, which costs less than $200. The main difference between consumer-grade watches like Fitbit or Apple Watch and this device is a high resolution of raw data and a long battery life, which allows us to record continuous data across multiple weeks without charging. And the scalability of this device has already been demonstrated. The UK Biobank is a longitudinal study of middle and older-aged adults, over 100,000 of whom wore these devices for 7 days. By leveraging this data, we found that lower amplitude of sleep-wake activity was associated with a higher risk of progression to Alzheimer's over about 8 years. However, as you can see in this Venn diagram, if you click, sorry, it's just a circle now. Thank you. The UK Biobank study has relatively shallow phenotyping, which relies on medical records. The cohort is not diverse and primarily middle-aged. Implementing actigraphy data collection alongside the uniquely deep clinical and biomarker data in NACC would provide high-quality data for high-impact science that isn't possible with existing data sets. Next slide, please. At Stanford, we've been very successful in implementing this data collection. We started in collecting in fall 2021, and since then have collected more than 200 total recordings from 191 individuals, or over 2,500 days of data. We've leveraged these data to investigate cognitive and biomarker associations with sleep and 24-hour activity, as well as specificity to clinical phenotypes. On the right, you can see differences in 24-hour activity and sleep efficiency across healthy older individuals, Alzheimer's disease, and Lewy body disease, as well as associations with tau pathology measured by PET imaging. Importantly, we've made this 24-hour data available to our collaborators within the ADRC and also at other institutions. Next slide, please. So central to our proposal is the infrastructure to collect and analyze this data. We're proposing to collect data from 60% of enrolled participants at Stanford and Vanderbilt during the pilot phase. When a participant consents to actigraphy recording, the Stanford Hub will mail a device via the U.S. Postal Service with instructions and a paid return envelope. Participants also receive an acceptability survey to assess potential barriers to participation. When the device is received at Stanford, it's uploaded to a secure server where the file is processed through our established pipeline, which includes quality control and extraction of metrics like sleep and physical activity. These metrics will be packaged in a spreadsheet and uploaded to NACC, along with the raw triaxial time series that can be processed any which way to the delight of any researcher. The emphasis here is on standardization, open source replicable processing, and making data freely available to researchers everywhere in the same spirit as clinical imaging and biomarker data already available through NACC. Last slide, please. Bear with me on these animations. I hope I have convinced you that real-world sleep and physical activity data would be a valuable resource towards developing digital biomarkers for early detection and differential diagnosis in Alzheimer's disease and related dementias. The research-grade high-fidelity data we will collect can be translated to inform both clinical care as well as algorithms for consumer devices, which are increasingly popular with older adults. Furthermore, because we're using open source data and software, the platform is device agnostic and there is therefore potential to integrate other devices and previously collected data. Last one. We know from talking to other centers about this proposal that many ADRCs would like to collect this data, and we're providing a roadmap. After a successful pilot, we plan to invite all centers to join us. Thanks very much.
Great. Thank you, Dr. Weiner. Who would like to ask the first question?
I'll ask a question.
I think, okay, Hugh and then Jason. You came up at the same time.
Sorry. You mentioned that you see this as an early detection platform. How do you define early detection, and where, when you see the first signal through some of your data here, how does that compare to when you see the detection on by other means?
Yes, thanks for that question. So, our past work using PET imaging has shown that there are signals early on, like for example, in people who are amyloid positive but have no symptoms. We do see differences in sleep efficiency in those groups. We also saw in the UK Biobank data, again, although it's only defined by subsequent health records, that people who had lower activity at baseline were more likely to progress in the next several years. And then interestingly on that point, there's even a stronger signal for people who went on to develop Lewy body disease in that study, so suggesting that there may be disease-specific differences as well.
Great. So basically, you're in comparison to PET imaging and sort of amyloid positivity, you're able to detect that sort of in symptomatic patients, similar.
So the way I imagine that playing out in the real world would be, if you were someone in your mid to late 60s who had a Fitbit or a tracking device, anyways, you're not going to need an amyloid PET scan or a spinal tap, but you might have a digital biomarker from your watch that could tell you, you have activity similar to someone who progresses, maybe time to see a doctor or neurologist.
I see. So in that application, it's sort of a screening.
Hugh, I'm just going to give other judges a chance to ask questions because we have a very short amount of time.
Yep, sorry.
Yep.
Thank you.
Jason.
Simple question from me. Does the device capture light dark cycles?
So the device does have a light sensor, yes. And it's not, my circadian colleagues would say that it's not great for picking up very detailed light information, like in terms of the spectra of light that, those researchers would want. But we can tell whether they're outside, whether they're in a dark room. So I think that this application of the device actually has been used to basically tell when someone has turned the lights off and is getting ready for bed. So that's another data stream coming from the device I didn't focus on. Yes.
Thank you.
Bose, your turn.
Thank you. Thanks for the presentation. Two quick questions. One is 14 days sufficient to get a signal and develop algorithms? The second is, are you anticipating open access algorithms being developed by any number of groups, or do you have a commercial partner?
We do not have a commercial partner to put that out there. So we are treating everything as open access at this point. That's how we've been approaching this. And that's how we would plan to go forward with these data, making them shareable in that spirit. And your first question, I'm sorry, remind me your first question.
The 14 days.
Oh, the 14 days, right. So, so the sort of standard in the field of wearing wearable accelerometers is 7 days. So we've improved upon that, but I'm certain that there would be increased signal with longer wear times. So by settling for 14 days, which we've been really successful for at Stanford, we're trying to keep participant burden at a minimum. But we have pilot studies going on at Stanford where we do have people wear these devices for several months to be able to compare how much 14 days is capturing versus capturing several months. So that's an ongoing area of research for us.
Okay, so yeah, in this
so I'm sorry, we're doing Q&A for the judges right now because the judges won't have a chance to ask the teams later. But you'll have time to ask later in the breakout.
okay.
That's okay. Nope, I'm so happy that we have such an excited group of viewers to come see these pitches. I do think, Hugh, if you want to finish up your last question, the question you were halfway through, I think that'll be the last bit we have before we can move on.
No, I'm fine.
Okay. Well then, I think we will transition into the judge scoring bit. So thank you very much, Dr. Weiner, for your presentation.
Thanks all for the great questions. Appreciate it.
Okay, judges, I'll give you a few minutes to submit your scores before we move on to the last pitch for this first half. Okay, let's move on to our final pitch of this first half. And I'm very pleased to present Team Clarify, Speech Analysis and Keystroke Tracking for Early AD Detection, led by Dr. Moore.
Hi, nice to see you all today, and thank you so much for this opportunity to present our proposal. Next slide. A recent study found that only 8% of expected MCI cases are diagnosed, which is a shockingly low figure that underscores the need for better early detection. Hispanics, Latinos are particularly affected, with just 5% of cases diagnosed. ADRCs need better ways to screen participants for early detection and accurate diagnosis of ADRDs, particularly among Latinos and other groups underrepresented in ADRC research. Further, as you can see in the figure on the right, traditional diagnostic methods often lack sensitivity to detect cognitive change. Day-to-day variability in testing can overshadow true cognitive abilities due to a myriad of contextual factors. Innovative, low-cost, remote, and scalable approaches are urgently needed to address these diagnostic challenges and to ensure equitable access to disease detection and effective treatments for all individuals at risk for ADRD. Next slide. In collaboration with the UCSD Shelley Marcos ADRC and the South Texas ADRC, our study aims to enhance early identification and cognitive impairment by leveraging speech and typing behaviors from everyday smartphone communication. We will generate data in Hispanic and non-Hispanic Americans in both urban San Diego and rural South Texas settings, leading to the development of culturally and regionally tailored assessments. As seen on the left, speech will be collected via active data collection using the Key Elements Remote Speech Biomarker for Cognition, or the SBC for short. Participants complete 2 gold standard neuropsychological tests while voice recording on their smartphones. Harnessing AI and automatic speech analysis, the SBC incorporates 85 features of speech, including different temporal, semantic, and task-related aspects of speech production, into their biomarker score calculation. Keystroke dynamics data, as represented on the right, will be collected via passive data collection over 30 days using Sky by Keywise AI. Sky is 100% passive and continuous. Participants install the Sky keyboard on part of their device's operating system and then just type on their smartphone as they normally would. There's no further action on the part of the user. Sky only collects typing metadata, that is, typing patterns such as typing speed, use of backspace, use of autocorrect, etc., and never collects the content of what is typed, which is important to preserve user privacy. The combination of these two validated, low-cost, clinical-grade technologies could aid in early identification of persons for enrollment into ADRC studies. Ultimately, NACC sites could use these tools systematically to assess cognitive change over time. Next slide. The low-burden, remotely administered nature of the SBC and Sky enhances feasibility of our project. Both digital biomarkers have been robustly validated in English and in Spanish and across cohorts at risk for ADRD. The SBC is currently available in 8 languages and was validated following the Digital Medicine Society's V3 framework. It can robustly detect early stages of ADRD risk and is currently employed in clinical AD trials as a pre-screening tool for cognitive decline. Sky's versatile keyboard supports multiple languages and facilitates bilingual typing. It's been validated as a digital biomarker of processing speed and executive function in diverse cohorts, and in ongoing work, we're finding it's able to differentiate Hispanics with and without ADRD risk. The keystroke dynamics elucidate real-time changes in circadian rhythms and inter-individual variability, offering valuable insights into cognitive variability relevant to MCI. Next slide. The impact of this project is multifold. NACC sites could use our tools to increase the screening efficiency and expand enrollment into ADRC studies. Data collection can occur 100% remotely, yielding a cost and time savings to ADRCs. Remote data collection expands access to screenings for diverse and underrepresented groups and helps measure cognitive change over time. Smartphones are the most penetrating technology in the world, making them ideal candidates for low-cost, hassle-free tools for data collection. There's no need to purchase extra sensors or hardware. Next slide. Our solution is highly scalable to the ADRC program and beyond. It employs fully remote, clinical-grade technologies that are already deployed in real-world settings, including in clinical trials. If the combination of the 2 digital biomarkers provides a more sensitive screening tool than either technology alone, both companies, Key Elements and Keywise, will co-create combined outputs into a new user dashboard for large-scale deployment. Further, our team is committed to sharing raw data with NACC to advance research and accelerate clinical discovery. In addition to testing the efficiency of combining these 2 digital biomarkers, our project will examine whether participating in our low-burden digital biomarker study could serve as a gateway to future willingness to participate in ADRC research. Our low-cost solution uses a modular design for easy integration with the ADRC program and other healthcare initiatives. It could also expand screening and improve assessment in underrepresented and marginalized communities. Next slide. Dr. Koenig and I will lead the highly experienced team with deep expertise in cognition, technology, data science, and clinical populations. The team includes leadership from both ADRCs, Dr. Hilzebeck and Salmon, as well as expertise in demographic differences in AD risk, Dr. Sunderman. Dr. Demos will lead the data science and analytics team, and he'll work closely with the data science teams from both QIs and key elements. Next slide. With that, thank you for your attention and happy to take questions.
Thank you. We're now going to transition over to Q&A. Would any judge who hasn't had a chance to ask a question, Linda's jumping right in for me. Linda, go ahead.
Thank you. Thank you for the presentation. This is great. Maybe I just want to kind of get more information about like the settings of the deployment and say how many, is it kind of a one-time data collection or is kind of a collection through multiple times? And I do have a second question, which is in regard to how much training or what kind of training you want to give the research team to standardize the prompt when you talk to the individuals here in participants. Thank you.
Yeah, sure. So we're proposing to collect data in 200 participants at 2 different time points with a 12-year gap in between. So they'll do the keystroke data collection for 30 days, and then they'll do the key elements speech tasks at both different, at the zero month mark and then at the 12-month mark. We're going to actually be enrolling participants from UCSD from the ADRC registry of folks, which are participants who've never previously participated in ADR research, to see if participating in this fully remote study would actually then lead them to be interested in future engagement in other ADRC studies. And it's going to be integrated into the clinical site at South Texas. In terms of training of the staff, we have lots of experience training staff in helping participants install the KeyWise app on their phone, as well as installing the Key Elements app. And then our staff are going to be available full-time during the remote data collection for any tech support and questions. We're also able to monitor participants through the dashboards. And if we find that people aren't contributing keystroke data, for example, for a couple of days, our team reaches out and troubleshoots that with them.
Great, thank you. Bose.
I'll wait for any other judge who hasn't asked to go.
I think, oh, I can throw it out. Vinny or Omkar, do either of you have questions? No, Bose, I think you're on deck.
Okay, well, thank you. 2 quick questions again for you. One is, what is the approximate commercialization, the cost to deploy the 2 applications for the period of the study? Again, with a view towards scalability. The second is, it's great that the raw data is going to be shared, but is it fair to assume that the prompts in the apps are proprietary to the 2 companies?
Sure. So the cost for both companies is a licensing model of either license the tech per year, NACC would do that. And it's reasonable and comparable to other digital and cognitive assessments, and was highlighted in our proposal in terms of the budget line items. And then the other question was about, sorry, can you remind me what the other question was?
Yeah, the raw data.
Raw data.
For anyone to develop the algorithm, they might need the apps and the prompts, but I'm guessing those are proprietary to the companies.
Yeah, so I'm in addition to my role as professor at UCSD, I'm also a co-founder of QWise, and then my colleague and MPI, Dr. Koenig, is a co-founder of Key Elements, and both the companies have agreed to share not only our composite scores and the biomarker outcomes, but also all of the raw data.
Okay, Rachel.
Hi, just a quick question. How are you going to disaggregate if any other family member or caretaker were to use their devices? I guess it is more to the keystroke data, yeah.
For the keystroke data specifically? Yeah, so we're able to identify unique digital fingerprints with the keystroke data. So we see consistently with people that an individual has their same pattern that is day after day, the same within that individual. And my pattern is going to be different from your pattern, going to be different from someone else's pattern. So by looking at the data in our algorithms, we're able to detect if it is that individual or if it is someone else. With getting, though, the high frequency of data that we have, which is, every time someone interacts on their smartphone keyboard, whether it's typing a text message, whether it's sending an email, whether it's posting on social media, whatever it is, we're collecting that keystroke data. And so with that high frequency of data, if we have a couple instances where someone's, say, a kid jumps on the phone and sends a couple texts, that's not going to affect things. We do always encourage our participants as well during these data collection periods to not share their phones with their family members.
Okay, and Shwen, and this might be our last question.
Okay, thank you. Quick question. I think you mentioned that you've already validated this for MCI, I believe. Can you share like accuracy and specificity numbers, as well as, is this to validate the combination of keystroke plus vocal? Is that the main goal of this? And what happens if you get, participants who do one but not the other? And like, what is the study dependent on? Do you need the full complete set in order to get it accomplished?
Yeah, I'll let my colleague, Dr. Koenig, chime in on the validation piece. And our proposal is to see if the combination of these technologies combined is going to be more effective in early diagnosis and early screening of risk for cognitive decline. We'll also examine the trajectories of both of the technologies independently and just see if that additive effect is stronger than either alone. And Dr. Koenig, do you want to chime in on the validity piece?
Sure. I mean, it was shown a bit on one slide. So we try to separate different stages with an accuracy around 80%, which is based on the speech. So we kind of, and that was really large cohorts in different languages, etc. So we were expecting, well, that's kind of also the research question here, if we are improving this even now with the combined approach.
Thank you.
Thank you, team. Great job. So judges, we're now ready to submit your scores for this team. So please take a few minutes to do so. And then I believe we're going to move into a short break so everyone can go refresh their coffee. So get those. So the sooner you submit them, the sooner you can get more coffee. It's a win-win for everyone. Hey, everyone. I know it was a short break, but we're ready to make our way back and into the next set of presentations. So if I could have all my judges back in the room. For those of us who are back already or may have joined us for the first time, just a quick another set of reminders about our format for today. So please do not interrupt presenters during their pitches or judges while they're asking questions. During the Q&A, again, the Q&A during this session is reserved for the judges, as it's the only time they can ask their questions. It is really important for the judging process. But for those of you in the audience, there will be a virtual poster session happening after the pitches, and you'll feel free to go between all the different breakout rooms, connect with all the teams, and ask your questions then. Next slide, please. So jumping right back into it, and I do hope the presenters are back from the break, I am proud to present Scalable Next Generation Smartphone Gait Assessment for Early Detection of AD and ADRD, presented by Dr. Adeli and team.
Good morning or afternoon, everyone. If you're excited to present our project on next generation contactless gait assessment technologies. Motor disturbances are known to be among the earliest manifestations of AD. In this project, we aim to develop a smartphone app for gait and posture control assessment based on an extended version of the clinically accepted short physical performance battery, or SPB, by leveraging recent advances in AI and computer vision. Our app will have bidirectional communication with the individual through AI supervision, conduct autonomous motion tracking, and unlock a new range of digital measures beyond clinical scores. In the scope of this project, we aim to work with 120 participants across 3 ADRCs. We will first develop an app, initial version of the SPB Plus app, and validate it against gold standard clinical SPB and motion capture data in the lab at Stanford. We will then further validate the app in the community settings across 3 ADRCs to evaluate usability and reliability in the wild. Finally, we will evaluate the preliminary clinical validity of select digital biomarkers and biomarker candidates. Toward this, we assembled a diverse cross-functional team consisting of experts across ADRD, engineering, and psychology at Stanford, Boston University, and UCSF. With the recent breakthroughs in disease-modifying drugs for AD, there is a growing need for cost-effective, scalable, and easily administrable screening tools. Among the key early manifestations of neurodegeneration are changes in motor function, including gait and posture control, which can appear years before the onset of clinical symptoms. While most traditional app-based assessments rely on IMUs to quantify digital measures of gait and postural control, computer vision brings the opportunity to measure 3D motion with much greater detail while including the full body. This means we can not only estimate distributed test scores, which are known predictors of adverse events in older adults, but we can also extract an unprecedented variety of digital gait and mobility measures. In other words, this allows for identifying potential biomarkers that go beyond simple parameters like gait speed, potentially enabling the detection of novel, more subtle indicators. One major challenge for unsupervised physical assessment in the community as well, the lack of an expert that guides patients through their task. In this project, we will use large vision language models to understand human pose and guide a user through tasks, as shown in this step-by-step illustration supervising the individual. Moreover, this also allows for the reliable detection of adverse events, such as falls. Concerning accessibility, smartphones have seen a surge in adoption among older adults, which means that we can reach a very significant portion of the population, including those in low resource settings. With the extensive AI assistance, the proposed assessment will be more inclusive and accessible for older adults from various socioeconomic backgrounds, thereby helping to reduce the digital divide. In terms of the feasibility, our preliminary data from Stanford supports the idea of smartphone-based computer vision to guide gait markers in both patients and with MCI and Parkinson's disease. Moreover, our data and published research show an association of SVB scores with neurocognitive measures. We do have the smartphone-based motion tracking technology mostly developed, as evidenced by multiple recent publications and a patent from the group. We also have leading expertise in the development and use of the large vision language models, which is the key component for AI supervision. And finally, we currently have an IRB for SVB video recordings approved and one in review regarding the app development. We will develop a new IRB for the multi-ADRC project. By relying on a smartphone app alone, our solution should both fit and scale very well to the current ADRC program and beyond, with a minimal additional cost and effort for personnel, as well as the possibility to extend measures to the community setting, thereby also making repeated measures easier. During this project, we aim to contact the FDA early on to adjust evidence for future approvals. And in terms of deployment strategies, we are thinking of two scenarios. First, licensing the underlying technology in a white label fashion, and second, directly commercializing the app to healthcare providers, pharmaceuticals, and possibly insurers. And finally, we are thinking of many different potential application scenarios beyond early detection of AD. Thank you very much.
Great, thank you for the presentation. Judges, do we have a first? Who wants to take the first shot? Linda, go ahead.
Yeah, thank you for the presentation. I just have a very quick question. Can you maybe share with us a little bit more about from your preliminary data, what's the difference between, or is there any significant difference between the AD patient and the Parkinson's disease patients?
So that's actually a very good question. We are right now evaluating this with respect to the differences between Alzheimer's and Parkinson's disease. With the preliminary data, there was not a strong significant difference between the two, but the cohort of the comparison was not that large because enough data with video recordings from both cohorts were not that strong. But we did find very strong correlation between MCI and healthy controls.
Great, thank you. Barbara?
Yeah, thank you so much for the presentation. Can you tell us a little bit about how you're addressing equity in your proposal?
So what we depend on is just this smartphone app, and which is actually accessible to everybody, could be downloaded directly from App Store too. In order to make sure there is a good and diverse population in the data, we aim to provide smartphones to those participants who do not have access to iPhones. And for those, we are actually starting with the instructions in English language, but because these are instructions, they are all easily, especially using these newer large language models that we are making use of, it's actually very easy to have different languages beyond just English.
Great, thank you.
Yeah. No, go ahead.
Okay, Jason. Oh, I can't hear your audio, Jason. I don't know if you're somehow still muted or your microphone got shifted. Nope, still can't hear you. Anyone else hear him and that's not me? Okay.
Jason, if you want to just type your question into the chat, we can voice it after Hugh's.
Yeah, sounds great. Hugh, why don't we jump to you and we'll troubleshoot.
Great. I'm just wanted to confirm, is the only sensor on the smartphone that you're using the camera? And if so, what requirements do you have in terms of resolution and the ability for the camera to capture the video?
Yes, that's a great question. Yes, in this proposal, in this work, we are only using the cameras, but I want to also give you maybe an early heads up that we are experimenting with the depth sensor on the newer iPhone. So it's a combination of camera and depth sensing technologies, and that's why we are testing this on newer iPhones, iPhone 13 above, and that, as I said, if participants do not have access to those, as part of this project, we are giving them an iPhone for the period of the study.
Thank you.
Great.
I think I solved it. Can you hear me?
Yes, we can. Go ahead.
Okay, so sorry about that. So it's my understanding that participants have to have an iPhone, and you'll give them one if they don't. That's great. But I must have missed it. What exactly does the participant have to do unsupervised by themselves?
Did you say unsupervised?
Yeah, what do they have to do to actually collect the data?
Yes, so the only thing is that on the unsupervised part is basically only opening the app, and then the app gives them, the AI provides the supervision required of placing the phone in the right place, then detects the person, looks at the pose. Okay, I can see you now, walk for 8 feet and come back. Now find a chair. We need to do the chair stance test and so on, and balance test and so on.
Okay, and are there lighting requirements? Like if it's too dim, will it still work?
Yeah, so these are all of the things that the supervision part
Gotcha. Thank you.
Takes care of. Yes, if there's a light like right behind the participant, it asks for changing the location, so the lighting is better.
Okay, great. Thank you for the questions, and then thank you, Dr. Deli and team, for the pitch. I think we're going to give our judges a chance to enter their scores at the moment, and then we'll move on. It's great seeing the variety of pitches and submissions to such an open-ended, call, and seeing how everyone's using technology to the full advantage to really diversify the data available. It's really great to hear everything today. So, okay, let's bring on our next presenters. We're going to be talking about remote digital monitoring to detect behavioral and neuropsychiatric symptoms in ADRD. So come on up, Dr. Rhodes.
Thank you, Dr. Roberto. We can go ahead and move to the next slide. A major problem in dementia research is that there's a critical need for more objective measurement of behavioral symptoms. We often think of Alzheimer's disease primarily as a cognitive disorder featuring symptoms like memory loss, but changes in behavior are nearly universal, with an overwhelming majority of patients developing symptoms like depression, agitation, even things like hallucinations and delusions. And importantly, these are not just psychological reactions to the disease, they're actual manifestations of the same brain changes that cause the cognitive dysfunction. But behavioral symptoms are vastly understudied compared to cognitive changes, in part because our established methods for measuring them are flawed, to say the least. Most patients aren't able to reliably report on their own symptoms, so we typically assess them by asking their loved ones to reflect on their mood and behavior at infrequent clinical and research visits. This kind of measurement asks caregivers to condense months worth of behavior into a single score on a rating form, and it fails to capture important aspects of the patient's environment that can trigger or exacerbate symptoms like over or under stimulation or unmet care needs that patients lose the ability to express on their own. So not only does this give us highly subjective information, but it relies heavily on caregivers, the people who are typically suffering the most, to report on some of the most distressing and stigmatized symptoms of an already devastating disease. Together, these problems with measurement have stunted the development of the kinds of sophisticated neurobiological models for behavioral symptoms that we desperately need to build new interventions, both pharmacological and behavioral. Next slide, please. Behavioral symptoms have an enormous impact on patients and families, one that I see in my clinic every week. They affect over 90% of patients over the course of their illness, including up to 60% in mild and preclinical stages of disease. In fact, changes in mood and behavior can be the very first symptoms of Alzheimer's, starting even before the onset of cognitive decline. Behavioral symptoms are also a major driver of functional impairment and caregiver burden. They predict disability above and beyond the effects of cognitive impairment, and they take an enormous personal and financial toll on patients and their families. This is in part because they lead to a greater need for hospitalization and skilled nursing care, which nearly doubles the annual healthcare spending for patients with behavioral symptoms compared to those without. Next slide, please. Our solution to this problem combines the objective and the subjective to identify scalable digital biomarkers of behavioral symptoms using the Aura Ring, a compact and unobtrusive wearable that allows us to collect continuous multimodal data on our patients. But what can wearing this ring actually tell us about behavior? Well, it turns out quite a bit. Within all of us, there are systems in our bodies that influence our behavior in ways we don't even realize. So for example, there are predictable changes in heart rate and breathing that signal shifts in mood states and behavior. These metrics are highly sensitive to behavioral symptoms and have been shown to predict which patients will develop symptoms like agitation, sometimes even decades before they're diagnosed with dementia. We're also able to gather data on things like movement and sleep that tell us important information about the contexts in which these internal changes occur. We can measure these metrics with this little ring and validate them against gold standard laboratory methods that have been developed and refined by members of our expert study team. Ring data will be combined with daily smartphone assessments and fed into interpretable machine learning models to develop digital biomarkers of behavioral symptoms in a sample of individuals across all stages of Alzheimer's disease. So it's important to note that our project expands on what the Ring data can tell us on its own by combining it with important information on daily symptoms and activities to identify digital biomarkers that are both contextualized and reproducible. And finally, we plan to conduct qualitative interviews with participants and their families to gain insight into the user experience and acceptability of this kind of digital monitoring. Next slide, please. We have a multidisciplinary team of clinical scientists with overlapping expertise in Alzheimer's disease research and clinical practice, as well as complementary areas of expertise in digital monitoring, wearables research, biomarkers of emotion and behavior, and bioethics. We come from the University of Pennsylvania and the University of California, San Francisco, home to two exceptionally well-resourced Alzheimer's disease research centers with high recruitment rates and dense clinical research infrastructures to help execute our proposed project. Next slide, please. Our overarching goal is to improve measurement and detection of behavioral symptoms across all stages of Alzheimer's disease by using wearable technology to develop scalable digital biomarkers of symptoms like anxiety, agitation, that can be used for diagnosis and disease monitoring. We also hope to identify individual and environmental risk factors for behavioral symptoms before they occur and use this information to improve existing treatment models. And we seek to do all of this with methods that are more objective and less burdensome for caregivers. Importantly, we are committed to sharing any and all data collected and derived from this project with NACC, with the hope that digital biomarkers of behavior can be further validated and adopted by ADRCs throughout the country. And with support from NACC and Gates Ventures, our project would represent an important first step towards disrupting the status quo of behavioral symptom measurement with some innovative technologies. So next slide, please. Thanks so much for your time and the opportunity to present this proposal. My team and I are happy to answer any questions from the judges at this time.
Great, thank you, Dr. Rhodes. Who wants to ask the first question? Jason, thank you for volunteering.
You mentioned that the data would be shared. Can you expand upon that a little bit? Raw data, process data, what are we talking about? Thank you.
Yeah, no problem. The Aura Ring the data will come pre-processed to some extent. So there is a cleaning and a pre-processing that's going to happen with any sort of proprietary wearable device. But that data will be fed into our machine learning models, and all of that will be shared, as well as the algorithms that we use and develop as part of our project. So we are interested in sharing as much data as we are legally allowed to, but I think that because it's coming from a company like Aura, there's maybe a slightly greater restriction on the precise rawness of the data.
Great, thank you. Hugh.
Do you have any preliminary data where you've developed any classifiers out of the combination of the Aura data and the survey data?
We haven't developed any classifiers, but we do have some preliminary data where we have looked at the correspondence between Aura measurement of heart rate variability and hardwired laboratory measurement, which is the gold standard. And we saw a very nice correspondence around 85% or 0.85 in just a bivariate correlation, which was promising for us enough that we felt it was worth exploring more and getting more data.
And separately, do you have any experience in terms of compliance with the daily smartphone diaries?
Yes. So this is a challenge for anyone doing that kind of work. And our plan is to incentivize participants and study partners with additional financial compensation for anyone who is found to complete, more than 85% of the daily diaries and wear the ring, greater than 85% of the study period. And so we'll be providing that and outlining it all during the informed consent process with the hope that it will improve or reduce missing data.
Thank you.
Great, Rachel.
Yeah, I actually had the response to the last one was helpful. Maybe I could dig in a little bit further there. I was a little bit confused because the majority of the proposals are around behavior symptoms, and all of that information is going to be captured in the daily diary. How is that actually being tied to the Aura Ring, and how do these two kind of work with each other? If you could just provide a little bit more.
Sure, great question. So the daily diaries will collect information on which symptoms were present throughout a given day, but people will also have the opportunity to do more event sampling style reporting, where if they observe a behavior in their study partner, that they're able to log it the time that it occurred. So we can kind of temporally associate the patterns that we see from the ring data with discrete episodes or events behaviorally. And then anything that is not captured in that kind of real-time fashion, we will follow up with study partners to try to get an estimate of when behaviors occurred, so that even if we don't have a kind of one-to-one temporal association, that we'll be able to say, well, the data from these 4 hours on Monday, we know that there was anxiety and agitation occurring during this window. And so it won't always be, exactly when the behavior occurs, but we will have a general sense.
Great. And Shwen, I think you're our last question.
Okay, thanks. I think Rachel pretty much asked most of my question, but I just wanted to check how long the duration of the study is and how, based on current knowledge, like when do you anticipate behavior change, and does that fit the timeline?
Yeah, so we propose studying people for 14 days. I think there's certainly room to extend that. That's the length of time that's recommended by ORA for developing more individualized data. And we intend to recruit individuals, only people who have evidence of behavioral symptoms within the last month, to try to increase the likelihood that we're actually going to be capturing an occurrence of symptoms. And I think that in the preclinical and mild stages, this, I think, naturally will be less frequent, but we will likely enroll people who have the more characteristic early changes like depression and anxiety that are actually likely to exist on, most days by definition. So we're hopeful that by targeting people who have evidence of behavioral symptoms within the last month, we'll be able to, actually capture some behaviors and not be monitoring people who aren't exhibiting any.
Great. Thank you, Dr. Rhodes, for answering the questions and for your great presentation. We'll give the judges a quick moment to submit their scores before we move on to our last presentation of the morning/afternoon, depending on where you're joining us from. I'm really excited to be, participating in this as part of here at University of Washington. It's actually our Innovation Month. It's the last day of UW's inaugural Innovation Month, so it's fun to participate and cap it off with a pitch competition like this. Okay, well, let's go on and bring our final team up. And this is evaluating the visual-spatial memory eye tracking test, or the VisMet, on the Linus Health platform with Dr. Vickers and team. Bring us home.
Thank you. Hi, everyone. My name is Casey Vickers, and I'm a neuropsychologist at Emory University's Goizeta Alzheimer's Disease Research Center. And I am excited to be here today to share with you some of our work on passive visual-spatial memory testing on mobile devices. Basically, we're putting the eye in AI. Next slide. So we all know that dementia, Alzheimer's disease, and related dementias present a global problem. Today, I'm going to focus in on one specific part of that problem, which is early detection. Next slide. Traditional measures of early detection rely on paper and pencil-based administration, such as the Montreal Cognitive Assessment, or MoCA. Next. These types of measures have known limitations. So they're not only burdensome to patients and the healthcare system, but they can actually lead to pretty high levels of frustration in our patients. And there are known biases based on things like race and education. Next slide. So in thinking about this gap, our team feels we found a solution, which is measuring visual spatial memory. So what we know from the literature is that visual spatial memory is very sensitive to the earliest Alzheimer's disease pathology. Particularly visual pattern separation tasks have been shown to be sensitive to early pathological changes in Alzheimer's disease happening in the hippocampal entorhinal cortex, which you can see highlighted on the slide. So these visual pattern separation tasks have a long-standing history of use in non-human primate studies and human infant studies because they can measure memory without reliance on language. And in fact, they've been shown to be sensitive to 10% hippocampal lesions in non-human primates. Next slide, please. So in response to this gap, our team has developed a visual spatial memory measure that is called VisMet, and it is administered by an iPad. This task is brief. It takes about 4 minutes to administer. It's passive. It provides objective eye tracking data, and it is language independent. So I would like to show you guys a demonstration of what this looks like from a patient perspective. If we could go to the next. Thank you. So when patients are shown this, they are So basically what happens when patients are given this task, they'll be told just to enjoy the picture show. They're not told to remember anything specific. And then they're shown a series of images. Now we go through this encoding phase, which includes 10 images. All of these are novel to the patients. After we've gone through that encoding phase, we bring those photos back and we actually add or remove a component of the image. And then in that recognition phase, the question is, do they notice that that piece has been added or removed? Although this is very simple for our patients to do, there's a lot of complicated technology happening in the background. So our team has developed AI algorithms to actually turn this eye tracking data into that memory data that we're interested in. Next slide. So to provide you kind of a visualization of what these data look like, you can see here we've got a sort of yellow circle that's moving. This is an actual gaze path of someone who has taken Vismet before. So you'll notice they're looking at the bird, they're looking at the bike seat. And then when we take away that bird, the question is, how often are they looking back to it? The idea here being that if they're looking back to something that's not there, they remember that it has been removed. Next slide. So to date, we have administered Vismet to over 1,000 participants at Emory University. In addition, we have a longstanding partnership with the Linus Health team and have been able to deploy Vismet through their platform in a beta version within the BioHermes study. Across these different areas, we found that Vismet is an effective predictor of cognitive impairment with an AUC ranging from about 0.76 to 0.78. And I'm showing you data here on the slide from one of our early publications, which shows that there's, in addition to this really high AUC, we see distinction between healthy controls, people with MCI, and Alzheimer's disease, which tells us that we're picking up on that progression over time as well. Next slide. So for the current project, we really have two kind of primary goals. So the first one is to standardize Vismet administration so that we can actually deploy this nationally. And a key component of that is developing an edge computing solution for processing the data. The second thing we want to do is deploy and test Vismet on the Linus Health platform across multiple ADRCs. Next. Next slide. So to develop this edge computing solution, we've partnered with our Linus Health partners, and basically what we're trying to move toward. So our current version of Vismet relies on a cloud computing platform where those raw image data come in, we send them to a secure cloud-based platform, we process that data, and then the data kind of comes back to the researcher. What we'd like to develop is an edge computing solution where those raw data are actually processed right on the iPad so that there's no kind of loop to get back to that data. Now, this not only saves quite a bit of time, it also improves patient privacy, reduces burden and cost, and enhances data sharing. And this would certainly help us ingest the data back into NACC, which we are committed to. Next slide. So once we've done that, we want to test this in 300 participants at 3 ADRCs across the country. So we've partnered with the UC San Diego ADRC, the Boston University ADRC, and we certainly would continue to collect Vismet data here at Emory. And we've chosen these 3 sites strategically to get a sort of nationally represented demographic. Next slide. So in summary, Vismet is a novel digital tool that represents low burden to patients and provides rich and objective data. It presents an opportunity for us to increase equitability in AD screening, and it's highly scalable. Next slide. And the current project would allow us to scale Vismet nationally to the ADRC network, and it would create critical infrastructure for global scaling and remote administration. Next slide. And last but not least, I would love to introduce you guys to some of our project team. From Emory University, we have experts in cognitive function and Alzheimer's disease, as well as healthcare data informatics and AI. We also have our partners at Linus Health, who are experts in scaling and commercialization, and our partnering ADRC PIs. Next slide. And we are happy to answer any questions that you may have. We've got 3 representatives from these different buckets here with us today, and welcome your questions. Thank you.
Great, thank you. Who wants to ask the first question? Okay, Hugh, jumping up.
Yeah. Yes, I'm curious about the the performance that you require out of the camera on the iPad in order to track the eye movement? Does it have to be a specific distance away? Does it have to have a certain resolution? Does it have a certain video frame rate? All of those kinds of questions.
So I'm actually wondering if Gary Clifford may be a better person to answer that.
Sure, I'm happy to take that. So the frame rate, we actually only do 1 frame a second for the eye tracking, so it's highly average. So it doesn't require a particularly high frame rate to identify where everybody's looking. The second question was around, or second sub-question was around distance. Because we have a calibration phase where they look at the corners of the viewing platform, it's somewhat independent of the size of the device and where they are in position to it. Of course, there's some limitations on that. You know, if they were a very long distance away or very close to it, then the calibration would fail. And then there's a feedback loop that tells them to move back a little bit or move closer to the camera. So that calibration of just looking in each of the corners solves the issue. Did I get all of the questions within that?
Yeah, that's great. Thank you.
Wonderful. Barbara.
I might have missed this, but is the work that you're proposing initially to take place within the ADRC at a visit at the ADRC? Or are you proposing that the iPads would be given to people in their homes?
Really great question. So what we're proposing for this study is that it would actually be embedded within the UDS protocol at these different ADRCs. So that negates the need for additional recruitment and things like that. We wouldn't be administering it remotely at this stage. It would all be happening in the clinic as part of that standard visit, which is how we administer it now at Emory.
Great. Bose.
Yeah, thank you. I presume that the app comes preloaded in the tablet or the iPad. And a related question to that is it a subscription model again, like a licensing fee for the number of tablets in which this is installed?
So I'll handle the first part of this and then maybe have Sean hop in if there's anything specific from the Linus Health side you want to add. So the way that we have, so because this would be in a research context at this point, we would basically provide the preloaded iPads, so sites wouldn't need to do all of that setup. And then from there, you know, right now, because it's on that research platform, I don't anticipate there would be extensive costs associated with that, but I'll let Sean speak to that.
I think the only thing I would add is Linus is really committed to working with Emory and researchers to keep costs low for research studies. So we have a long history of optimizing and decreasing those costs for our partners. It's probably a per license model, not a per test model. And yeah, I'll leave it there.
And does the participant get a readout?
So at this point, the participants do not get a readout. This is actually something we're hoping to kind of move closer to with that edge computing. So right now, there's a pretty lengthy gap between when they take the test and then when the data is actually processed. With the edge computing, there would actually be an opportunity for the researchers and clinicians to kind of see those scores almost immediately. And that would actually present an opportunity, right, for us to then consider if this is something a patient could get a readout of.
Okay. Great. Well, thank you so much, Dr. Vickers and team, for your presentation. That brings us to the end of the pitch portion. So I just want to say thank you to all the presenters for jumping into something new, experimenting with us, and sharing your great ideas with the group. I'll now transition back over to the NACC team to facilitate the poster session portion, and I'll see all the judges in the deliberation room in a little bit.
Thank you, Jessica, for serving as our wonderful moderator. And thank you to all of the presenters for your outstanding pitches, and to our wonderful judges for their great questions and for lending their expertise to this process. It's been fantastic. And thank you to our audience for coming here today to support all of these teams. Digital is alive and well in Alzheimer's disease and related dementia space. That's exciting to see. And we look forward to building on this further in partnership with Gates Ventures and others, and hopefully all of you. So I'll pass back to Brittany to help us navigate to next steps.
Thank you so much, Sarah. Next slide, please. Yeah, so let's give another round of applause to all of our awesome presenters. Those pitches were all incredible. Thank you so much for all your time and effort. We're really excited to see what the judges come up with as they discuss these pitches. I think they're going to have a lot of hard work ahead of them deciding which 3 to select, or which 1 to 3 to select. Next slide, please. So yeah, next up, our judges are going to be convening to a closed deliberation room to make their recommendations on funding and on selecting the 1 to 3 winning teams. We'll be announcing those selections in early to mid-June, so please stay tuned for that. You can grab the QR code or the bit.ly code for our website there. And next slide, please. And beginning at 11:45, so in approximately a little less than 10 minutes, we'll be jumping to our Ask Me Anything virtual poster sessions. So all of our audience members are welcome to hop between all these different breakout sessions where you can interface directly with the pitching teams and ask them questions that you had during their pitches or learn a little bit more about their pitches. So please jump back in at 11:45 a.m. PT, which is, I believe, 2:45 p.m. ET, to jump into a breakout room and learn more. Next slide, please. So yes, thank you so much for coming. We'll see you all back here at 11:45 for those breakout sessions.